Oh, what are your thoughts? So, I mean, specifically, we've been working on looking at the value proposition for all types of stakeholders on the NHIN Exchange. I think the thing that resonates the most with providers that are considering being parts of organizations that end up being exchanging data either through other mechanisms or through the NHIN is that it will help them improve the quality of care. I think that we can talk a lot about how it will help them become more efficient. It will help them to become more engaged with their patients, be able to communicate with their patients better. But at the end of the day, what I find with practicing physicians and even students, I think, is how will this help me improve the quality of care that I deliver. I think that we can talk a lot about this will reduce your overhead, this will make you more efficient, you'll be home by 5. All those things are wonderful. And the docs I know are like, I'll believe it when 300 other docs tell me that's what they're experiencing. But we do have a lot of practical experience in the real world where docs at places like Regan Street, CareSpark, and others that are coming to us and saying, I will not go back and practice medicine without coordination of care. I will not take those risks with the patients that I care for. And I think that all of the other wonderful things that we talk about, reducing administrative burden, getting better aligned with CMS from a quality reporting perspective are nice decorations. But the thing that is really going to bring this to the provider, and I think the patient community as well, is that this is the standard of care. And practicing medicine any other way is impeding you from being the best doc that you can.
I just want to add that the providers need to find out what's happening in their state as to the exchange efforts, because I'm not quite sure, and Steve could talk to this, that providers can actually connect directly with the NHIN Exchange.
Yeah, that's a good point. And right now, at least, in order to participate in the exchange, there needs to be a contractual relationship with ONC, or one has to be a federal agency. And that really, I think, is an interim requirement that will hopefully resolve itself in the near term. There are some particular reasons why that has to be in place, and I understand them, and I think it's just part of the evolution of the exchange. But so that's a good point in terms of today. But I think your question was more, down the road, and certainly and Lisa Jenkins is here and can certainly speak to the state initiatives that are going on through the our grants. There are a lot of them, and there will be plenty of opportunities for physicians to plug into different exchange mechanisms that hopefully those organizations will be NHIN Exchange participants. So you really get to the same place.
One thing I might add as well, too, major concern for the clinicians that I personally have heard over the years I've been involved in this discussion is a concern about the liability for participation in exchange. And I think if you're thinking about that, from a professional organization perspective, it's obviously better to be operating under some kind of governance structure than without any rules of the road at all to follow. That does kind of leave you totally at the mercy of defending yourself for whatever decision you did or did not make. But if you can point to, these are the rules, these are the standards of care, they have been agreed upon, and that's what I'm complying with, that does give you some level of protection from liability.
Start?
Sure.
I would speak primarily to the fact, again, based on the experience of my interaction with clinicians, it is the ability to exchange information with the federal agencies, the VA and DOD in particular. For a physician who has patients in common with folks that are served by those programs, by those agencies, they have a very difficult time now coordinating care. And that has been a huge benefit, value for the clinicians that has been articulated to me many, many times.
Yeah, I would concur with that. I think the trajectory here, the federal agencies have embraced the NHIN Exchange, and there's actually some recent studies that demonstrate pretty compelling ROI. Particularly, there's one by the Case Center that was recently published that looked at the SSA Met Virginia, what was a pilot, is no longer a pilot, and demonstrated some very compelling ROI for the hospital. Bon Secours St. Mary's Hospital in Richmond, Virginia, in terms of their cost savings from the production of medical records to support disability determinations, as well as the reduction in length of time of processing disability determinations. So I think that that's a great question, and that's just one recent tangible third-party report. But I agree with Lisa. I think the decision by the federal agencies to embrace the exchange, NHIN Exchange, is very important and will be a big driver of participation by HIEs across the country.
I think even earlier today, some of the folks from DOD were talking about their commitment to achieving meaningful use and employing the NHIN Exchange. I believe that for many of the folks that provide care in America, that no practice can be profitable without some component of revenue coming from a federal beneficiary program of one kind or another, CMS, Medicaid, DOD. And what we have carefully implemented is a mechanism that is flexible enough to mature through time, while enabling our federal agency partners to realize the requirements that they must comply with. And I think that having them at the table as part of the NHIN Exchange helps ensure that 5 years from now or 10 years from now, we will still be able to retain them as participants in this program. Yeah. One question that we got from over the webinar was regarding the DURSA itself as an artifact. That is a public artifact at this point, available on the ONC website. And I think one of the things that we might be able to do as NEHIC is put together some of those tools that are publicly available. All of the coordinating committee's operating policies and procedures are available. All of the approved current versions of those operating policies and procedures are actually on the web. We also publish typically within a week, the coordinating committee meeting minutes, meeting notes that discuss the various operational activities of the coordinating committee, including things where they're looking at how to improve their own processes, including information that is everything with the exception of protected health, not PHI, but commercially protected information, which we respect a great deal of the participants coming on board, and they would have the privilege of announcing that they are actually participants versus one of our own entities doing that for them. But as far as the actual instruments and tools that have been produced with relation to the DURSA, and I think all of the trust tools that you introduced during the presentation are available, and there's a lot of things that I think as a community, and from the experiences that we start to gain as new types of entities start to join the exchange, tools can be developed as a community, and perhaps NEHIC can help facilitate that process where we all learn from one another's past performances. I also know that the technical assistance program is very, very much involved in that, and maybe you guys could speak to a little bit about what's available through the leadership.
Forum.
I'm going to misspeak the leadership forum.
Do you want to start, Molly?
Sure. Well, I can reiterate that's true for the State Health Information Exchange Cooperative Agreement Program. We do have an extensive technical assistance project or program available to our grantees. We cover all elements that are required under the funding opportunity announcement for that program, and of course, one of those are the legal policy area. So one of the when it comes to trust agreements, this is absolutely something that if a state or a group of states working together are interested in having some kind of expert assistance, they can ask ONC. And sitting next to me is Lisa Jenkins, who is one of our team members leading that charge on TA, so she can get into a little bit more about the details of what's available out there. I'll also say there are some other opportunities being offered by ONC. One of them in particular is through RTI, and they are also working with multi-state groups on legal and policy issues related to privacy and other actual elements of this program, and that's something where our grantees and states can look for additional assistance.
And because the audience for this, I think, is there are a lot of folks in leadership roles within the states. I do want to emphasize the fact that a lot of what is there in the way of technical assistance resources right now, it has been compiled really over the past 4 years with some excellent work done by the AHIMA Foundation and folks that were providing support to states at that time, including development of governance and trust documents and data sharing agreements, et cetera. So some of the states may have posted their documents online there in the resource toolkit that's there. I'm most familiar early in my role here with what has happened in Tennessee and Virginia, but I'll point to Tennessee, and Melissa is very familiar with the fact that one of the projects that the state funded there was a very, very thorough assessment of the state laws and whether they hindered or facilitated health information exchange. And they used that assessment as a mechanism for really kind of inventorying anything that would need to be addressed in the concept of legal and policy changes, adaptations, or enforcement. So I think that's the type of process and tool that we hope that all of the states will use, or any of the organizations that are doing working on health information exchange.